It is well said that if you don't stay updated and upgraded, you will be outdated. Water also loses its purity when it is stagnated. So, the flow of new knowledge is always necessary to keep the branch vibrant for every fraternity of the science. So, let us discuss about the today's topic, that is recent advances in the anesthesia for the shoulder arthroscopy. We will discuss the basics of anesthesia in the shoulder arthroscopy, then what's the new and how is the scope. Anesthesia for shoulder arthroscopy needs the special considerations because in the last few decades, the shoulder, which was the least important part of the orthopedic department, evolved as an area of the great research and the progress. The fourfold increase in the arthroscopic procedures also leads the anesthesiologist to dig into details of these procedures. These are the minimally invasive planned daycare procedures, which demand the early recovery after the surgery and the discharge for the patients. The patient's profile is also varied. The severe pain requiring the intense analgesia, different positions for the surgery, hypotensive anesthesia if required, and the serious complications. And the most important is the neuroanatomy of the shoulder, which is very complex. When we consider the patient's profile, on one end, there is a fit sports person with the instability or the unstable shoulder, and other end, there is a frail elderly patient with multiple comorbidities and the painful shoulder. The problems with the both are totally different. Why there is severe pain when it is a minimally invasive procedure? Because during the arthroscopy, the distension of the capsule, elastic retractions, sometimes bony debridement, they are causing pain. Shoulder is a dynamically movement having joint and it is richly innervated by the nerves. Rotator cuff injury is the most painful procedure, which is almost 3 times more painful amongst all instability repair procedures. Positioning, as you all know, lateral decubitus and the beach chair position, these are the two common positions given for the shoulder surgeries. When lateral decubitus position is safe for the anesthesiologist, the beach chair is best for the surgeon. And we have the many problems with this. The cerebral ischemia due to hypoperfusion in a position will be a problematic one when we are giving the beach chair position. Similarly, the airway compromises can be handled very difficultly when there is a sitting position. The basal gyrus reflex, which is a dreaded complication of this position due to hypotension bradycardia leading to cardiac arrest, is a very dreaded problem with the semi-sitting position. Thus, when we see for the evolution of anesthesia for any shoulder surgery, it was the only GA which was previously thought of as it was an upper limb procedure. In 1970, Binet discovered the interscalene block, and this changed the whole scenario where the introduction of regional anesthesia come into play for the shoulder surgery. And now we have many newer blocks in the regional anesthesia proper, which have evolved the anesthesiologist as shown in the picture. Now, what are the disadvantages and advantages when we consider the general anesthesia and regional anesthesia? General anesthesia is suitable for all procedures, but still it is less important when we consider the pain relief, as the A delta and A alpha fibers, which are having the periarticular innervations, the opioid sensitivity is less. The opioids could not block the pain sensation from these fibers, which is very much nociception for the shoulder joint. And thus, RA is the only solution for the pain relief when we consider the regional anesthesia. Early recovery, as you all know, is very good for the regional anesthesia proper. Thus, when we see the evolution, it is the regional anesthesia which we have to discuss as the recent advances. The blocks start with the interscalene block, which was the gold standard over years. But now the list is increasing and we have the more specific blocks with the advent of the USG. This is the list of multiple blocks in combination which we will see in detail. All these blocks are called as diaphragm sparing blocks. Before we go into details of the regional anesthesia, to know the beauty of this regional anesthesia, we should be thorough with the applied anatomy of the shoulder joint, where dermatomes are supplied by the two plexuses, that is cervical and the brachial plexus. Suprascapular nerve, axillary nerve, medial and lateral cutaneous, and the intercostobrachial. These are the 4 different nerves, including the supraclavicular nerves from the cervical plexus for the shoulder joint, as a sensory supply for the skin. When we see about the myotomes, again, there are variations in the nerve, like axillary for the deltoid area, lateral pectoral for the pec major, and lower and dorsal scapular for the infra and supraspinatus. The joint capsule, which is the main area of interest when we are seeing for the arthroscopy, the 25% of the supply is by the axillary nerve, whereas 75% of the capsule, which is posterior-inferior area, is supplied by the suprascapular nerve. Shoulder is having two joints and the both capsules are maximally involved or the supplied by the suprascapular nerve. Again, other small branches from the plexus or from the cord have the small contribution, and the shoulder capsule is supplied by all these nerves, and that to be blocked for the regional anesthesia alone when we are considering it as an anesthesia purpose. Osteotome, again the two bones, rather three bones, humerus, scapula and the clavicle. So all these supplied mainly by the suprascapular nerve and some contribution from the subscapular and the axillary nerve. So let us see the blocks one by one. This is the benchmark in the evolution, as I have already described, can be given with the landmark, PNS and the USG, all methods. The target for this block is the C5-C6 root at the level of the cricoid. The traffic signal pattern on the USG is the markable, and it is the block mainly used as the anesthesia and both analgesia or the postoperative analgesia purpose. Still, the grip strength is affected with the block. If all the benefits are there with the block, then why need to have the more research? This is the danger. The involvement of the phrenic nerve or the phrenic nerve palsy leading to hemidiaphragmatic paralysis is the problem with the interscalene block. With the USG only, we have recently come across all these findings like diaphragmatic excursion, which is responsible for the 75% of the inspiratory volume at the rest, is affected because of the hemidiaphragmatic palsy. And there is 40% reduction in the FEV1. With the ultrasound, the excellent sensitivity and the specificity regarding the diagnosis of the hemidiaphragmatic paralysis has shown that there is 100% involvement of the phrenic nerve with the interscalene block. And all other complications, that is neuraxial spread, intravascular injection, pneumothorax, are common with the interscalene block. So all other blocks, they are evolved. The first is the superior or the upper trunk block. When we see anatomy, as we go distal, the superior towards the superior trunk, the phrenic nerve will go away from the brachial plexus. So here the target is the upper trunk, not the roots. Incidence of hemidiaphragmatic palsy is 5.3% versus 72.5% as shown by the Kang et al. In his study. This block again is given for the anesthesia as well as analgesia purpose. But USG is must to identify the superior trunk. But it is a very good visible target under the USG. It is having the clearly defined margins with the large amount of connective tissue, which lead to less neurological damage. The next block is the supraclavicular brachial plexus block. This is the main block which we use as a spinal for the upper limb surgery. This is most common block for the upper limb. It is given with the landmark, PNS and the USG. But why this is not commonly used for the shoulder surgery? It is because of the questionable blockade of the suprascapular nerve. The amount of local anesthetic which is required is more, and still there is a questionable blockade with the suprascapular nerve. Again, the hemidiaphragmatic palsy is not less, it may be up to 34%. And the risk of pneumothorax is always there when we are not using the sonography. With these two blocks, the newer block which was evolved is the shoulder block as such, which is a combination of the suprascapular block, axillary block, and the supraclavicular nerve block, which is for the sensory cutaneous supply. So, including only suprascapular block will not be of help when we are considering the shoulder anesthesia. But this block can be used for the simple procedures like the frozen shoulder procedures. It is again can be given with the PNS and the USG. With the help of PNS, infraspinatus and the supraspinatus contraction can be easily determined. This is the block which is used for the anesthesia as well as analgesia. HDP is up to 0 to 2%. As it is giving less side effects, this is best block for the daycare procedures. Axillary block is again a component of the shoulder block. It is always to be combined with the suprascapular block for the complete result. Anesthesia is questionable, but analgesia is very good when we are using this block for the postoperative analgesia. There is no risk of hemidiaphragmatic palsy as we are going very distally and we are blocking a single nerve. But radial palsy may be a problem due to more proximal spread when we are using more volume, that is more than 10 ml. This is a component of the shoulder block only, that is superficial cervical plexus block, including the blockade of supraclavicular nerve. We have given this block long ago with the landmark technique also, where we are using this superficial block with the blockage of all the supraclavicular nerve under the sternocleidomastoid. But with the help of USG, this can be given with the little solution, that is 4 to 5 ml of the local anesthetic over middle scalene, which is sufficient to block the cutaneous supply for the shoulder. And this is the only block which gives the cervical plexus blockade for the shoulder. The new block which has come into existence is the costoclavicular block. This is the block which is given infraclavicularly and blocks the other nerves which are supplying the shoulder joint, that is lateral pectoral and the intercostobrachial. This is the block which is used for the anesthesia as well as analgesia. There may be a sparing of some cutaneous nerve which can be blocked easily with the help of landmark technique. But the incidence of HDP is 0% with this costoclavicular block. As the compartment at this level is very tight, and it is shown in the cadaveric studies that there will be a retrograde spread of the local anesthetic blocking the suprascapular nerve. This is another block, that is the infraclavicular block, which is also inferior to the clavicle and giving the good results when it is combined with the suprascapular approach, that is the posterior approach of suprascapular nerve, as I have discussed earlier. Again, the USG and PNS both can be used, and anesthesia as well as analgesia are non-inferior to the ISB as shown in the studies. The posterior approach for the suprascapular nerve is more helpful as compared to the anterior approach. This is another block. We all know the pain block for the hip, but it is also for the shoulder. This is periarticular nerve group blockade. USG is must because we have to identify the specific facial planes while giving all these blocks. But there are limited RCTs. Only case reports have been presented in the literature. But this is the only block where diaphragm is confirmed paired because there will be only blockade of the sensory supply and there is no blockade of the motor nerves as such. So this block can be used for the analgesia during the other procedures. As arthroscopy is a minimally invasive and needs more pain relief rather than the anesthesia or the motor blockades as such, this may be a block of choice for the arthroscopy if proved in the RCTs in future. This is the good block we have already used for the other abdominal as well as the thoracic surgeries. Now it has evolved for the proximal level surgeries. When we are giving this block at the C7, C8 level or the T2, T3 level, there are case reports which have presented that there will be a spread and there will be a blockade of lateral pectoral, subscapular, axillary and the suprascapular nerves. It is again also a good block for the analgesia as well as anesthesia. As phrenic nerve is paired totally and we are blocking the nerve proximally, so this may be a good block, but as there are no RCTs, this block is still in future. The local infiltrations and the anterior glenoid or the facial plane blocks, these are the blocks which recently discovered, the case report I am referring is in the 2024 only. This is the block which was used by the orthopedic surgeon as the trigger point injection. With the help of USG, we can identify the planes between the muscles and we can easily block the sensory nerves in all these facial planes. As with the tab block for the abdominal surgeries, this facial plane block may also help us for the shoulder surgeries, where we can only block the sensory infiltration to the shoulder and thus the pain, and there will be no muscle paralysis after the surgery. So now let us discuss what is new in the additives, opioids and the local anesthetics. The perineural injections, that is combination of local anesthetic with the dexamethasone and the dexmedetomidine, have tried for all these shoulder blocks and proved to be good for the surgeries for analgesia as well as anesthesia. Liposomal bupivacaine is recently coming, and in TIVA, the remifentanil will be a choice for the shoulder surgery. Up till now, we have seen multiple blocks as we have listed earlier, but how to cope by the case-to-case approach and what to consider when we are considering all these blocks for a specific case. Let us discuss. This is the first case, that is 30-year male, recently joined the army, who is complaining of recurrent shoulder dislocation and posted for the Bankard's repair. Here, the most important point is the occupation of the patient. Any nerve injury will be problematic for this young male when we are considering the anesthesia. So my choice will be a general anesthesia with regional anesthesia, where I will use the facial plane block or the pain block or the ESPB for the analgesia or the combination of regional with general anesthesia. In the second case, where the 66-year-old male with multiple comorbidities like diabetes, hypertension, and a COPD who is presented to us with the right shoulder dislocation, who is posted for the diagnostic arthroscopy, I will prefer only regional anesthesia as an anesthetic block, that is may or may not be with the sedation considering all other comorbidities. So this is the patient who should be done under the anesthesia with regional anesthesia. The blocks you can try may be an infraclavicular block with the suprascapular nerve block, or the shoulder block as such, or the supraclavicular nerve block with the costoclavicular approach, and the superior trunk block alone. This is the third patient who is 48-year-old male, laborer by the occupation, having left shoulder pain, and there is no any history of the chronic illnesses. But his pulse rate is 48 per minute. Though the ECG is within normal limit, how to consider for the anesthesia when he is presented for the rotator cuff repair? The plan may be general anesthesia with the regional anesthesia, where regional anesthesia should not be ISB because considering the bradycardia of the patient and the high vagal tone, the problems like basal gyrus reflex may be more when there will be a combination of interscalene with the general anesthesia. This is the approach which combines the general anesthesia with the regional anesthesia as such, which gives the maximum benefits regarding the intense intra and postoperative analgesia. There will be no patient movement and the discomfort when we are combining both regional and the general. The benefits of regional as well as general may be combined with this combination, and we have the early recovery because of the great pain relief. Now, what is my approach for the shoulder? I will always prefer the combined approach with the general anesthesia and the low dose superior trunk block, which is USG guided. The ropivacaine 8 cc with the dexamethasone of 4 mg. I will always use the low concentration of the ropivacaine for in combination with general anesthesia. And the local infiltration with the ropivacaine at every port, that is all 3 ports of the shoulder surgery. Thus, to conclude, as a modern anesthesiologist, you should hone your skills of peripheral nerve blocks with the diaphragm sparing blocks for the shoulder arthroscopy. Choice of regional technique should be patient specific, considering the safety, satisfaction, and the functional outcome. When perfection is not attainable, but if we chase the perfection, we can catch the excellence, and that's the end. These are all my references. Thank you.